Okay, morning everyone, and welcome.
Hynie, bonjour. Sarah Rockindishnakas. Shebananing and Donjaba, Takaranto and Day. Takaranto, a Mohawk word. The place in the water where the trees are standing. The place where the fish weirs are. My dog and I spend a lot of time walking. It's my favorite way to move through this city. For me, it's a meditative action that isn't about negotiating bike lanes or public transit, but a time to slow down and really try to see the world around me. Concrete sidewalks, parking lots, now covering the rivers and trails that once flowed freely. The Petun, the Huron-Wendat, the Haudenosaunee, the Anishinaabeg, the Métis, the Mississaugas all made their homes here. And many other nations expanding beyond these groups traveled through for commerce and trade for thousands and thousands and thousands of years. I think of the other First Peoples' languages and the names they had for this place. I think of the ancient trails covered by the pressures of settlement. The waterways and the moderate climate of the Great Lakes made it a perfect place to fish, hunt, grow food, gather medicines and seeds for horticultural development. Rich, fertile, and abundant, Turtle Island's Mesopotamia. Many First Peoples and their goods traveled from here all the way to the Mississippi and back. Whenever I travel somewhere new, I try to find out whose land I'm on, and I ask, who are the original occupants here? So for Indigenous peoples, land acknowledgements are not only to assert our sovereignty and treaty rights of today, but it's also a way for all peoples to feel more connected to a place. Davenport might be a street now, one I walk down regularly in my neighborhood, but it's not just another thoroughfare. For me, it's an ancient portage trail that holds Indigenous knowledge. They say the animals made the first trails that led them to water, and the people followed. I imagine the deer and the moose once made this trail, followed by the people carrying their birch bark canoes, carrying their goods to trade, and bringing stories to tell. Nations from all over Turtle Island met and traveled through this land. Many languages were spoken. Alliances and decisions were made. People from different nations met and intermarried. The dish with one spoon treaty was made. Takaranto was a meeting place and land made up of sophisticated and cosmopolitan peoples and cultures that I see reflected in the city today. I wonder, is it something in the land and the water? Land acknowledgements might seem like a small and simple gesture, but like many of our ways, they are intended to have more impact and hold more meaning than the words alone. If we pride ourselves on diversity and equality, shouldn't our story include Indigenous peoples? In this era of reconciliation, we need to share the truth first. And reimagine the narrative of this land and this city together.
So it gives me great pleasure on behalf of our project team to welcome you to the sacred land on which Women's College Hospital operates, which has been the home and hunting grounds to Indigenous peoples for thousands of years, including the Huron-Wendat and the Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, and it invites us to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island. I'm grateful that as an immigrant, I have the opportunity to live, work, and thrive on this land. And I invite each of you to just take some moments to reflect on the history of this rich land. For those who are joining us online, feel free in the comments to acknowledge the land from which you are joining our dialogues this morning. So my name is Ibukwa Abejiride, and it has given me great pleasure to welcome you all back, for some of you who were here for our dialogues in April, to this 2-day of co-creation, knowledge exchange, networking, and thinking together about how to integrate health and social pathways for newcomers that are beyond technology and beyond healthcare. On this slide are all the members of the project team who have made this event successful, and who have sort of been the brains and the energy behind our coming here together. Also gives me pleasure to acknowledge that we are doing this with a lot of generosity from our funders, Social Science and Humanities Research Council of Canada, Quest AV, who is providing tech support today, has contributed some of finances and resources to make this event possible, Women's College Hospital, who has given us the space to do this, and the Dalalana School of Public Health, University of Toronto. So on the 8th and 9th of April, for those of you who were here, some were not, we gathered together for 2 days, a mix of keynotes, panel events, conversations, trainee presentations. I think many would agree that it was a very rich, interesting, and energizing dialogue. This graphic captures the output of a lot of central points in our conversation that day, and I just wanted to remind us of where we left off the conversation as we enter into new discussions today. So we agreed and acknowledged that intersectionality was key to understanding how different categories of newcomers experience their settling into Canada, and what that means for those who are more marginalized than others, depending on what pathway they are on, what migration category they are, which country they are from, and their lived experiences and fears. We recognize that community was central to the ability of newcomers to thrive. Also, just a reminder that we're using the term newcomers, but we mean that broadly and inclusively to capture all categories of newcomers, including all categories of migrants, including people with precarious status, refugees, asylum seekers, temporary immigrants, and permanent residents who have coming through that route. So we recognize that community was central to the mental health, well-being, and the feeling of welcoming and belonging that newcomers can experience being here. And there's a core need for wraparound support. We identified a lot of assets. You know, sometimes we come into conversations and think that the key thing is we're only going to look at the gaps and then we're going to reimagine something completely new. But one thing that came out strongly was that there are existing assets, programs, settlement organizations, volunteer groups. We heard about cultural brokers and peer navigators. We heard about policies and systems that are enabling. We also heard, though, that there's a need for there to be more concerted efforts for policy and advocacy change, and that this needs to be grounded on legislative instruments, and there needs to be an increased social awareness of the importance and relevance of migration and immigration to Canadian society as a whole. In acknowledging those assets, we also came to terms with the challenges that various categories of newcomers to Canada face with settling. One of the key issues was navigation and getting lost within the myriad of assets that there are. Health services, seemingly disconnected from social services, seemingly disconnected from community services. And this actually puts newcomers in this cycle of precarity and disadvantage that could be avoided. We recognize that there was a need to have systemic compassion and individual compassion at the same time. There was also hope about the opportunities to close the gaps, that by having an enhanced integration system and the mechanisms to drive it, to encourage cross-sectoral communication, to break down the barriers and silos that prevent people from coming in and feeling stable here to thrive. I remember Anna saying that, we bring humans, not workers, to Canada, and we need to keep people at the center of migration pathways and ensure that we are facilitating transition so that people are not forced to leave, but they choose to leave if they want to, not because they are forced to. We agreed on the fact that technology could play a very key role in helping bridge the gaps and divides, acknowledging that it's not a solution in and of itself, and that digital policy is actually health policy, just given the rate at which digital transformation is driving service delivery within the healthcare sector. And at the end of the day, we also acknowledge that there are things that we can control and there are things outside our circle of influence. But everybody needs to work together across sector, across disciplines, across divides to be able to build integrated pathways for newcomers. Before we go into the main gist of today through keynotes and the panel conversations, some of you already have in your hands copies of this comic that we've worked on. I think it's 4 months now, originating from the initial research activity that we conducted, engaging newcomers to understand their experiences of a digitally delivered healthcare service, virtual care. And Kyla, who is the key illustrator of this work, is going to be presenting her own work as a PhD candidate, but also reflecting on her journey as someone who has straddled the divide between science and creativity. We're very proud of this work because it was researchers coming together with people with lived experience of migration. So refugee, PR status, I think there was one person undocumented. I can't recall the details now. But we all came together as a group of 7, and we worked together week in, week out, figuring out the colors, the tones, the messaging, the language. How do we share this information back to the community that share their insights and their experiences? So I encourage you to look through the comic, share your feedback. You can also have a flipbook version if you follow the tiny URL link. But I think I will stop this presentation on this part actually, because I remember during the debrief when we're talking to our community peer researchers whose creative energies led to this work, one of them said, I want people to read this comic. I want newcomers like me to see these words, because then they don't have to experience the frustrations I experienced when I came to Canada and I had to figure out what virtual care is. So for us, this is really important work, and there are different modalities by which we continue these conversations. So for the next 2 days, starting today, we're going to be continuing exactly that, those conversations, starting with a keynote presentation by Professor Kevin Pottie, who I would introduce very briefly in a few minutes. Then we'll have scholar presentation by Kyla. Then we're going to start a series of panel conversations with presentations from Professor Michaela Hynie, Professor Bukola Salami, Professor Nancy Clark, and Dr. AKM Alamgir. And that will be followed by a moderated Q&A session. Delaney Cox is here, and I'm going to introduce her in a bit, who is going to capture all our insights through a very beautiful visual, and hopefully will let you out the door by 3 p.m. or just before it. So for wayfinding, if you need the Wi-Fi, here's the username and password. Right on this wall, you can also see the information should you need it during the meeting. Live streaming is ongoing. We have people who have joined online via Zoom. Beverages and snacks are outside. You can feel free to go out at any time. There's tea, there's coffee. If you feel it's not hot enough, there's a microwave just around the corner so you can heat it up. Please take note of emergency exits. There are 2 at the back. There's one right up front here. For those who would need to use some time to access the prayer room, if you go downstairs to the ground floor of the hospital, just ask at the security or volunteer desk, and they will direct you to the prayer room there. Kindly return your badges upon when you're done, before you leave, just so that we can use them for subsequent engagements that we're going to have. So with that, I'm going to invite Delaney to come up and introduce herself and tell us how we can make this also contribute to her creative direction today. Delaney.
Hi, everyone. I'm Delaney Cox. I'm with ThinkLink Graphics. This is great. I love this. So I'm going to be the graphic recorder here today. So I will be writing, similar to the graphic you just saw with Fuselight, which was quite beautiful. I will be taking all of your ideas, taking down all the notes from the presentations, concepts, feelings, everything like that. And I highly encourage that you also come and chat with me at some point. And I'd love to get some personal feedback as well, and your own personal experiences. So I'm really excited to be back. I was back here in November, and I had a great time, and I'm excited to see what you come up with today. Thank you for having me.
Thank you so much, Delaney. Thank you very much. So feel free, there are stickies on her table, so you can go at any time during the break or, take your notes and just stick them, put it down for her, and she'll be sure to capture it. So key personnel today, myself, if you need anything, feel free to reach out. Laura Sexstrom is here. She's going to be moderating our panel, but she'll also help with general event coordination. Isabel is over there. Isabel, could you wave? There's Isabel. There's Priya Saibal as well. Priya? There we go. Delaney, who just introduced herself. So everybody here to make sure that we have a very great time in these conversations. So with that, it gives me a lot of pleasure to invite to the stage Professor Kevin Pottie, who is a distinguished professor and research chair in family medicine at Dalhousie University in Halifax. Dr. Pottie's systematic reviews and patient-centered clinical guidelines have been transforming primary care clinical approaches for refugees and immigrants, homeless populations, and deprescribing solutions for the elderly. He has worked extensively with the Cochrane Collaboration, the Canadian Task Force on Preventive Healthcare, as well as with WHO headquarters in Geneva. He won the Researcher of the Year Award in 2021 and also recently received a Springer Nature Inclusive Health Research Award. I would say that Dr. Pottie's work embodies a dedication to fostering a diverse and vibrant research culture that accelerates medical discovery, and he has a shared vision of positively impacting health and quality of life. And just so you also know, he's a great biker, he loves going trail hiking, and he just gives us a lot of pleasure that we have the privilege of his time today. Welcome, Kevin.
Thank you so much. Actually, it's a real pleasure to be with you guys. It's nice to meet Nancy Clark in person and see Denise Spitzer in person. It's just, it's been a couple of years when a lot of Zoom calls, and so it's really, it's a nice feeling to get together. Looking forward to the dinner tonight. It looks like it'll be fun. I'm gonna go over a few things. Hopefully I won't create any confusion or misstep on this. I really feel like I'm maybe an imposter in this presentation, speaking about transitions in care, which I think has predominantly been more of a sociology and nurse background. It's been an area that it's been led by other groups, and maybe one that I'm just recently discovering, but I'll give you a few of my perspectives. So I've been moving around a lot, and people don't necessarily know where I am. So I've moved back to my home province, Nova Scotia, and after like 27 years in Ontario. And that's a Nookshuk that I actually built myself in Clam Harbour. And so I'm feeling very fortunate to be able to kind of return home. I always felt I'd be doing that at some point in my life. And I think anyone that's not lived at home often feels pretty grateful when they can do that. So I'm very lucky. I don't know if we need to spend much time on this or not. Some different groups want to spend more time on this than others, but I certainly declare that there's things I've done that might influence my thinking. So I wanted to try to reflect on access to care and health equity. Discuss this transitions in care, which I think is really interesting. And then consider opportunities with digital transformation and artificial intelligence. To some extent, I feel that this has been one of the guiding principles, is that what happens to people that when they come and they're healthier and they seem to not retain their healthiness, and we're always wondering what's going on here. And it's quite amazing that this has shown up in so many different outcomes, and we still, I don't think, have the answers for this, but I see it as a motivational force that we have work to do. So as are other people working on transition in care research? I should just ask before I say something wrong. Is this something you guys spend much time on, or? Okay, that's good. Not too many. I just got really excited about transitions in care over the last 6 months when I realized that the refugees and especially that I was seeing in my refugee clinic, are substantially different from 20 years ago, 25 years ago. And I realized that they were receiving, liver transplants, HIV treatments. They were receiving a lot more care than we had saw before. And for me, this brought up the situation, are we attending to the transitions from Turkey or United Emirates or Jordan, from different countries where they're actually receiving care, and they'd receive care from their home country, maybe Syria before that. So all of a sudden, I think it became much more important to not just to treat them like people that have just arrived and that might need, what do I do with my water there? Oops, there it is. Sorry. Yeah, so I got excited because I realized that this is a really fundamental area. Like, how do newcomers have transitioning cares across multiple, sometimes international, interdisciplinary, different languages. And I felt that we, in our immigrant and refugee health field, had not tapped in very well to the $100 million of U.S. research on transitions in care that have been done from a person, let's say from a hospital to community care. There's several different work has been done. And out of about 200 projects, I think there's 2 that were actually dealing with immigrants and refugees. One was on PTSD, but I realized we weren't really represented in this important field when I think our group are experiencing incredible transitions, and we have work to do to improve those. So I believe probably this transition in care language began in the 90s when in Harlem they were diagnosing women with cancer, but none of the women were actually getting any treatments. So it became really obvious that you can't just diagnose cancer and expect people in a disadvantaged situation to find themselves through the maze of specialty consults, investigations, follow-up. And so I think it's really drove home the importance that if you're really going to treat people, we must have a lot of support for people that are working through transitions. I think that from that cancer, a lot of specialists really were frustrated because a lot of times people are discharged home and then they end up back in the hospital in a short time. And that highlighted that there's work to be done in terms of how we transition people from hospital care back to community care. Diabetes care is a really hot topic, which I think relates a lot to our immigrant and refugee care as well, because any chronic disease has several different steps, several different interventions, lifestyle. So a lot of transitions going on in terms of care for that disease. People bring up the pediatric to adult care, which is also an interesting area. And then these are just examples. There's actually probably 20 more, but transitions to palliative care. So I just started to apply this a little bit to thinking about newcomers, where there may be people that are receiving care in their home countries, maybe in a community health worker, maybe never seeing even a nurse, or maybe seeing a practical nurse. They're having very different backgrounds, but then as they start to move through their system too, they might move from more community health worker to maybe nurse practitioners, community clinics, and I guess this transitions to different professionals will continue for quite a while, and then they arrive in Canada, and we know that they're a very mobile population. Anyone that's new often doesn't find their perfect home right away, so they're going to be moving around and doing further transitions to different practices, maybe in the community, maybe different cities. And so I believe that this is a really important thing to focus on to ensure health, because we want people to be able to learn and work and contribute. And it's a very complex system to be navigating, as we know. And I think we've all been working on the structural barriers for a long time, and I think the transition in care gives us an opportunity to maybe look at them in a little bit more of a timeline, maybe look at them a little bit differently, and potentially develop new interventions from care navigators to facilitators to other, and not simply focus on, say, language difficulties. To see it more as a process of care rather than just simply accessing care. So we know that accessing care is nice, but will the person understand what was worked on during the visit, what kind of education is needed, what they might have to do afterward. So there's a lot of steps that are involved in ensuring access to quality ongoing care. So we just about to submit a scoping review on this topic. We wanted to see what has been done, and we did find 42 studies, and we found 38 different transitioning care interventions. These were a lot of them very early studies. Virtually all these studies were done in Western countries. And the studies took place in healthcare settings, because I think a lot of the investigators were working in that area. But there were several, and probably some of the most interesting ones were happening in community settings. So how are communities developing transitions toward care that's outside maybe healthcare? So I think that is really interesting. Yeah, the navigation and education was a key element in these programs. I'm kind of excited about this because I think this is where AI or generative AI could play an incredible role. It's very challenging as a family doctor to people might have multiple problems. They're coming from different backgrounds, maybe different languages. So I don't really get to do the type of health counseling, education, information that I might like. I'd say constantly compromising, maybe trying to say, well, what could I do out of the 10 things I should do? And I just think this is a really exciting point for potential technology in the future. I think we have to recognize that there are many learning points that will have to happen over time, so you don't just learn everything at once. And I'd like to think that maybe this is one place technology could really help us. The studies, talked about the confidence, and I think that's a really, maybe confidence and agency could be one of the main outcomes that we're going to see from this, because we want people to feel that they can do something for themselves. They can figure out the system, they can get supports. And I think when they were involved in these interventions, it gave them a sense of confidence that they could play a role in their care. So when we look at all the other transitioning care areas, such as diabetes, cancer care, we couldn't find any mention of immigrants and refugees in those projects. It was very much kind of a standard population that spoke English, that were receiving these extra services to get, let's say, cancer care. And we couldn't find any representation from immigrants and refugees in these millions of dollars of existing programs that already exist. So this is something we've identified as something I think of primary importance, is that these other projects need to consider our populations. And then coordination and navigation is one of these key, really important factors here. I sat down with my new research assistant, Daveen. He just arrived from Cameroon, and we kind of talked about what he felt were some of the transitions that he's been experiencing or that he's experienced in his work in the Cameroons. So I think that the first thing is that, most people are really seeing a community health worker and not necessarily going much farther than that. And sometimes they're getting access to a practice nurse. The access to pharmacy is a little bit different than maybe in Canada, because a lot of people that can buy medications open their own pharmacy, and they often don't have training. So you have sometimes just lay people selling some medications, which could be counterfeit. And then we actually have there also are pharmacists that have training. So often, depending on how much resources you have, will determine the quality of the pharmacy care you get. And then eventually people might find their way to a medical doctor and medical specialists. And I guess this is, again, where the transitions start to become a little bit more complicated. They start to leave the community. And so Daveen mentioned how, the health insurance that a lot of people actually he had as a worker for Save the Children, that actually gives people a bit more status because the practitioner realizes they may actually get paid for something. And so I think that's an important, so you can see that people that don't have that are probably getting very minimalist care. And we talked a lot about this idea of a VIP status. I think our systems are always incomplete and maybe and not perfect, and it's hard to imagine developing a system that does not have somebody that cares about you that's making sure things work. And I guess that's what I think about with the VIP status. And a lot of people don't have access to that. When you don't have access to that, you could be very vulnerable along these care navigation pathways. I like to think that, depending which culture people are coming from, that the family doctor or nurse practitioner, medico cabecera, and people want someone that knows them, that knows the system. And I've had like 1,000 invitations to dinner. I've had so many newcomers that really wanted to bridge this thing like they do in other countries, because it's incredibly valuable to have somebody in the system that really cares about you. And I think they don't really necessarily feel like that in the regular system. We have, of course, boundaries in Canada. We can't really do those dinner parties, but like they do in other countries. But I just think the concept is that they do need somebody that cares about them. I think that's the bottom line. So just kind of like this, I can't really show you the step here because the podium's in a way, but I will show you the cells. It's just this, I'm sure you guys do a lot of work on health equity. I just think sometimes it's interesting as a point of entry, a point to talk about political will, a possibility to build provider capacity and to ensure equitable and quality services. I think equity also makes us think about the strengthening capacity of the state policy making. Points out inequities and structural barriers. And then I think that, especially in other countries, but I think also in Canada, but I don't have quite as close a connection to NGOs in my Canadian work, although we have definitely settlement worker connections. But I'd say in other countries, I think NGOs play a really key role in working with practitioners and patients. So I'm sure you guys have seen this before, but the importance of not dealing with equity, not equality. The Cochrane Health Equity Group, I've been really fortunate to be part of an international group of people that were working on new methods, new approaches, and trying to kind of contribute. Kind of like the slide, which was based on bed net in interventions in Africa. And so it's a reminder that the efficacy at the beginning was 20%. People may not have a benchmark, but 20 to 30% is about as good as our cholesterol medications, as most of our medications. We're often operating with interventions that are dealing with 15 to 30%. I think that's just important to recognize. So although these interventions are important, they aren't necessarily going to solve all the problems. So then when you have an issue of accessing this intervention, you have an issue of giving this intervention to the right people, then you have to have the provider that takes the time to actually, say, give the bed nets. And then you want the actual family or person to actually use the bed nets. And this is something from Don de Savigny from Swiss Tropical Institute, but I feel like this really drives home opportunities, but it's also reality of what really happens in real life, that we're not getting the 20% because there's a lot of reasons that things are not, so actually effectiveness is much lower. And this is something that I think focuses a lot of our effort in Cochrane to say what are these issues, how do we work on them. And then even when we have the 7%, this is actually, it's hidden, it masks inequities. Some groups are not getting anywhere near 7%. So even though 7% is the average, again, there's vulnerable groups that are getting less. So I just wanted to mention a project that I was maybe, I don't know, accidentally turned me into a researcher from a clinician who complained that there was no guidelines to support doctors that were seeing people from around the world. I complained about this for 4 years, and then University of Ottawa said, okay, I'll give you research time and you can do something about it. And I didn't actually plan to be a researcher. I was a clinician educator, but after 6 years of a really big project, I realized I'd changed, and I actually into kind of a, committing my efforts in different ways to help people, not just patient care. So we worked for many years with many different groups, and I think really to bring up the concept that we needed and newcomers deserved evidence-based approaches. And a lot of our findings were to stop doing things. So I think half of our recommendations, such as PTSD, was being aware that this could actually cause harm, and that pulling out the Harvard trauma scale on every newcomer is not actually a good way to practice. So a lot of our recommendations said, don't do something, maybe remain aware. But this was important because if the practitioner is spending all their time doing all of these non-essential prevention things, we really lose the actual person in the visit. So I like to think our biggest accomplishment was stop doing stool testing for newcomers. And I don't know if you are part of a family of 8 kids, you're the mother, and you say, we're going to do stool samples. So that we do 3 stool samples for parasites, 3 stool samples for culture and sensitivity. And then we find like a ton of things in these things, all these tropical diseases, you look them all up, it's really exciting. And then we give treatments for the few that we need to treat, and then we tell the mother again, we need to repeat all the stool samples. So for me, this turns into a 99 bottles of beer on the wall, but this mother is going to be collecting stools. She's just arriving, trying to learn English, and all they're doing is collecting stool samples. So we basically said, no more stool samples. So basically, we were able to focus it down to, let's say, 2 blood tests on 2 very important parasites. So this is just a simple blood test that were actually cheaper than the actual stool tests. So I feel really good about stopping a lot of those things that people were doing, I was doing myself, because really they weren't necessary and they're getting in the way of actual living for the patients. I think it's also good that internationally we've kind of been able to develop really similar guidelines. And I've always felt that was important because sometimes family members may end up in Europe, sometimes family members may end up in Australia. And so it's really nice now that I think a lot of our guidelines are quite similar in a lot of Western countries. So that family members, won't be confused or won't be wondering what the right thing to do is. So I think that's really exciting to have that consistency. I just wanted to talk a little bit about digital transformation, and it's very exciting, but has had mixed results. I guess the tractor took 50 years before it was actually really implemented in the 1950s. Some things, I think, like the smartphones have been incredible in terms of how many people are using smartphones. So this, generative AI and different things will have a variable uptake. But I think, as we know, there's just really a lot of things, exciting things happening in this area. When I showed Devine, my assistant, the slides for the PowerPoint, he really skimmed over all the equity stuff and all the barrier stuff. And all he really thought we should focus on was opportunities, with digital transformation and AI. he was very excited that there's something new that could actually be really helpful. So it's interesting, I was kind of surprised, but he really honed in on some of the excitement that's happening. You know, we have just a reminder that there's the early kind of mechanical artificial intelligence helped to translate like languages, write languages. So that was, you know, that was interesting, but all of a sudden AI started to be able to think and coming up with its new outcomes. And we know these aren't always perfect, but it's kind of incredible that a computer can start bringing new ideas that the actual programmer did not anticipate or did not even expect. And then the really exciting thing is that AI is now being able to capture feeling. A number of university profs are starting to use AI in education. You have a class of 300 people, and you can actually detect which students are maybe having depression, having difficulties, and you probably would have had trouble actually differentiating in the past. So I think there's a lot of exciting things that that AI is bringing. So I guess also the ability to kind of overcome geographic barriers to improve access to care. I like to think that the information that's available will help both the patients learn about diseases as well as the practitioners to ensure better quality of care. And ideally, access to these, you know, free online resources could be very, you know, be very empowering for patients and communities. So I think this is kind of exciting. This is just a quick example, a story of, I don't know, One Medical, if people have heard about this group. This is actually a general internist from San Francisco that decided to make his clinic more patient-friendly, make the experience better for his patients. And so he basically, you know, his motto was fall in love with your doctor's office. And his whole approach was improving the experience of the patients. But because he's from the US, he got to charge, let's say, everyone $200. And from that fee, he was able to develop digital platforms, a lot of different like services for renewals. He was able to do a lot of different things that in Canada we're not actually able to do yet. We can't, and I think you know, we're quite a bit behind this clinic. And Amazon kind of noticed this and bought them for $3.9 billion. So I just feel like there's exciting things coming. I don't think this is quite here yet. So he's actually sold the One Medical, and now he's focusing on Galileo, which is a $40 a year for people with less income. And he thinks he can do virtually the same thing maybe for people for $40 a year, and he's doing this in Spanish. So I think it's really interesting to try to take this innovation and apply it to other groups. So I think this is something he's focusing on, which is exciting. These things showed up to 40% of people using the digital resources quite comfortably. You know, in Canada, we're like this could double the number of family doctors if this was actually working. So the digital would handle 40%. So there's a lot of things that could happen in the near future on this. Anyway, this don't go into the whole system, but how we changed to the 24 hours, 7 days a week care, and how he was able to use like friendly apps and people. And I really think that this should be available for all of us, everybody. I think one of the big things is having a patient summary available. Kind of still embarrassed, and we don't have that much in Canada yet, but everyone should have a patient summary that the actual patients are developing and working with. So that's one of the ways he did that. But I find that what's happening in Canada, it's really hard for one clinic to actually do very much. So a lot of our innovations are coming from a provincial level. Ontario Health, Nova Scotia Health as well, is doing some things. They're starting to actually develop a summary for patient care. So as a practitioner in a clinic, I wanted to improve my clinic, but to be honest, half of my clinic doctors say, this isn't going to work, I don't like technology. And the other half say, then there's early adopters that want it. It's virtually impossible to do it clinic by clinic, at least. So we really need to advocate maybe for larger systems. We need to make sure that Ontario Health or Nova Scotia Health that are putting in these new programs are considering our population, because it's not going to be easy for us to do one clinic at a time. I think these generative AI models that cost billions of dollars to create are now turning into this accelerated AI models that people can use the original models to make their own models. They can start to regulate a little bit, control what the data for their models. So things are happening within weeks these days. It's incredibly hard to keep up with how fast some of this technology is moving along. But we know that having engineers doing all the programming is actually not going to be very effective. So we really need engagement of the communities, of practitioners. People really need to be engaged in some of these processes to make them useful. And I think this really highlights the importance for our newcomer populations. We really need to have them involved as well in the programming, adaptation, making sure we have the right data included in our data files. So just to highlight again, I just feel it's some really obvious things that are really much on the horizon. Self-management, mental health resources, well-being and lifestyle information is probably available like never before. I guess it's probably a little bit complicated as to what is fake evidence versus what is real. But a lot of studies are suggesting that this digital divide is actually narrowing. I felt like we had to be really careful. I felt really worried for newcomers. But when we have social media sometimes translating a lot of information into readable segments, we never had that before. And although some of it isn't that accurate, a lot of it is accurate. My research projects were trying to put guidelines onto social media. So this is like never before to have these packaged short messages in something that people have access to and are using. So I think it's a really exciting time, and it's not all about increasing digital divide. And I think involvement, of course, you still have to work hard to involve our populations and our patients and stuff involved in what we're doing. You probably heard there's a number of groups that are really wanting to make sure that the AI is human-centered. There's no question we need to be working in an interdisciplinary, intersectoral, collaborative way to make sure that the technology is useful, and no one really debates that. And for human rights in AI, one of the articles that I found in the New England Journal AI last month or something was authors saying it is probably unethical that we're not using AI in our practices right now. If we look back in time and we see how powerful our tools were, and that maybe the practitioners or people were not using them. So this is like, some people say, oh, things aren't ready, but a lot of people are saying things are actually more than ready, and it's the practitioners or other system elements that are delaying things. So I kind of found that was interesting, because it's true, I'm always wanting to make sure things are done properly, but at the same time, some of the stuff is so powerful now that when we look back, we're going to say, wow, is this the tractor? Are we, taking 5 years to put something into practice that could have actually helped a lot of people's lives? But there's issues with liability for tech companies, governance models, regulation of the data files, which you can make sure that people get the tools are developed with the right data. And it's also a little bit of a Western bias for sure, often because there's money generated from these AI products. But I think there's definitely room for improvement there. And that's it. Actually, that's not my email. I get my wrong email there. Sorry. Don't look at that email. It should be, say, dal.ca. I have like 9 emails. I got to try to reduce them.
So, Kevin, why don't we sit down and we'll have informal Q&A. Please. Maybe I'll kick it off, and then if anybody has questions, please feel free to raise their hands. So, Kevin, thanks very much for joining us today, and I really appreciate sort of balance between the risks and the opportunities with some of these. Thank you. So I appreciate that you have focused on both sort of the challenges and barriers for immigrants, but also some of the potential opportunities. One of the things, I mean, there's lots we could talk about, but one of the things I noticed when you talked about health equity, and you had 4 things, entry point for equity-oriented health, provider capacity, state capacity, harnessing NGOs. So one of the things I noticed there is that none of these were about making immigrants or newcomers themselves responsible for achieving health equity. So I really appreciate that it's not downshifting this responsibility to be active or attain care. And one thing I'm interested in particular is this idea of like, what is this entry point for equity-oriented political will? Sounds to me like you've worked with a lot of different groups. You've been able to build coalitions and partnerships across countries, within countries. I'm really curious, like, what is that entry point for you for health equity, and how have you been able to mobilize support for this and some of the initiatives you've worked on?
Yeah, thanks. That's a good question. I have been working really hard to figure out how we can bring generative AI and other digital transformations that are actually available, but not necessarily in Canada. So I've come to the conclusion at this moment that I really have to lobby the provincial governments. The way our health system is set up, and the way it's not necessarily, you can't just change your practice. So we're working within a whole system. So I think I'm really lobbying about, I think the provincial governments also want some of this as well. This could reduce costs, this could improve access. So I don't think that people are against this, but I don't see the immigrant and refugee populations represented in very many of the provincial plans yet. So I think that's what I'm trying to lobby for and say, this is great, but how are we considering the different populations? So that's, I think, where we're at with that.
So can I have a follow-up there? One of the things you mentioned, and I think is so important about the whole system, is the mobility of newcomers and how much they move around. And as someone who's lived in 3 different provinces and had challenges accessing care when I move around, how do you, we have a pretty fractured health system across Canada. So I'm curious, how do you see this transition in care? You talked about to different providers, different diseases, different, contexts, but this sort of mobility piece across the country, and how do you build that at sort of a political level that you've sort of indicated? You have ideas?
I know you guys are working on pathways, which I think is a good thing, but I've also experienced the diversity of services is huge. The telephone virtual care is not always good, but sometimes it actually is the best service for a newcomer because they don't have to travel to the appointment. Sometimes they prefer starting mental health in that way, discussions. So I kind of think what we need is a diverse group of services that people could access on their own. And at the same time, we also need to help build their agency because we'll really need a population that's able to kind of look after themselves. And I think we should have lots of different services, but at the same time, so I actually experienced I worked in a refugee clinic in London for the last 2 years, and most of my patients came in with smartphones and with apps in their actual language. I don't know if anyone uses the Strava app for running and stuff. So I have patients that don't speak any English that are on Strava. They're joggers. They're keeping track of what's going on running in other countries. It's really quite amazing how a lot of these resources are already in Arabic and French and probably Spanish, all these languages. So I found a lot of people are already using some of these apps that promote a healthy lifestyle. So I think we shouldn't underestimate people and feel that they have not, because a lot of them have discovered some of this stuff on their own, which I think is the ideal way.
Thank you.
Are there questions from the audience? Jay?
Should I just try to talk loud?
Do you want me to bring?
The right way to go? Okay. No. I think it's okay. Dr. Pottie, thank you so much for your talk. Really interesting. I think to frame, as Laura said, to frame it as transitions in care, transitions to Canada, and that as a transition in care is really interesting. Yeah. Thanks, Isabel. So something I certainly hadn't thought of before, but you've presented also this overview on health equity and equity and access to health services, and then also reflected on the role of technologies in sort of achieving that. And I guess I'm just on the tail end of a project looking at policy for digital health equity in Alberta, Saskatchewan, Ontario, and Quebec. And so we've identified this real patchwork of different sort of policy domains, and like it's not all in healthcare. Some of it is about just where is their infrastructure to access the internet, which won't be a surprise to you. And we're exploring these different ways of sort of making sense of this, like what's the approach here? And you referred to political will around health equity, and I see that there's a small literature looking exactly at that, like how do we build political will, and how is the messages being framed, and so on. But what I wanted to ask is about a health in all policies approach, and if you're familiar with that, and if you think that that's a possible sort of avenue to pursue here, acknowledging that it's not just about ministries of health, but also sort of other kinds of policy as well.
I think we're at an interesting period of history with what this generative AI could actually contribute. One example was a project from the US where they decided to put all of their patient information, surgical consent forms through a trained AI system. And in a split second, they actually had 100 different patient information that were all better than what they had before they put them in. Because this is just English, we're not even talking another language. So just making the English readable, you say, I want a grade 9 level description of this, and it actually is just amazing how gigantic. Then of course you could ask for that in different languages. So the idea that we're still like photocopying 5-year-old information about diabetes that's probably 10 years old because it's lagging behind in Spanish or something. So there's something really incredible happening. So the trouble is that there's the technology is really exciting, and the health and all policies is exciting, but I don't really think right now that policymakers and governments are easily keeping up with what's going on. So I think that's where we have a real dissonance, I see. Yes, we definitely want health and all policies, but what if the technology is moving ahead in leaps? It's not like slowly advancing. Are we ready, with our populations, are we ready to take advantage of this? Or are we still back in trying to do health and all policies, which is, of course, should be done, but yeah, I think there's something exciting happening, and I really exciting for our populations just because of the way you can translate, you can prepare documents in better formats, you can do patient education. Okay, one more example. So non-insulin dependent diabetic, so type 2 diabetic, they come to a point where sometimes they need to use insulin. Starting insulin is always a little scary because if you drop the sugar too much, you can have like car accidents and stuff like that. Or it's actually really challenging to get the right amount of insulin with the diet and the exercise to help people to be as healthy as possible. So they did this study in San Francisco where they trained a smart speaker of how to give patient information, how to understand insulin, their lifestyle, their diet. They put all of this, these were like not even tech people, this is just doctors that did this with some tech support, into a smart speaker. And they compared giving someone a smart speaker to help use their insulin, or giving them a doctor, nurse educator, multiple visits. And this study is really small. I guess it's a new one, but it's just so incredible that it took 12 weeks for the smart speaker people and 52 weeks for the regular people. You know, you can ask your smart speaker again and again, and it's not a stupid question because no one cares. You can ask in the middle of the night because that's when your question was. Like, this is kind of quite revolutionary that we can actually, we'll have access if we have good trained models. I'm not saying there's not risks, but that is like phenomenal. I just think I can't compete. As a doctor, I realize, you know, this is really exciting, and I want my patients to have access to those kind of resources. So I don't know if that's helpful or confusing.
No, it's the burning platform. Like, we have to just get on with it because these innovations can improve care for people.
And I'm really trying to do this for our immigrant population. It's not like a mainstream thing that people are thinking about immigrants during all of this. There's unfortunately a lot of money involved. It's still like probably some politics. So I just want to make sure that we're in this group and we're able to take advantage of this kind of thing. I'm sure other people are doing that too, but it's not easy. But I think we want to be in the game. And I think that, like, Daveen, my research assistant, who has just arrived from Cameroon, he saw this and he was immediately excited. He said, "Yeah, I want this. Forget those barrier things. I want access to this." Yeah.
Thank you. I saw two hands in the back. Yes. Yes, please.
Hi. Thank you for having me. Just a quick introduction. I have a startup. We help foreign trained immigrants kind of integrate to the economy. One of the challenges that we face is actually getting the message out. Like, how powerful is like technology, the accessibility of technology, and how it can help like kind of solve a lot of problems, right? So just relating, like, based off on that, like, what would you say your success looks like in like 3 months and in like 12 months, right? And how do you plan on achieving it?
I think there's 100,000 internationally trained health professionals in Canada. And so we're doing a project right now where we're actually developing a learning and a webinar platform to help those people understand evidence-based medicine, which is a little bit different than they would have learned in their own country. And this appreciation of this is quite fundamental as you shift into medical care in Canada. So they'll eventually get this maybe if they get into residency. But we're trying to prepare them to understand the post-COVID condition guidelines that are coming. So rather than just give them the guidelines and to take that to their community, we're actually preparing them to understand, and we're going to give them agency to talk to their community about, you know, health recommendations. So we're really trying to build a little bit of a community workforce. Some of those people will go on to be nurses and doctors in the system. Some of them may end up with other jobs. But I really feel excited about, like, looking at those people as a key opportunity. But we really have to you know, we're working with them. Our project is being run by 7, you know, of these people, and then we're using another 20. So we're basically developing a system that I think could receive and communicate, as opposed to trying to send directly to the patients right now. So I know that to me is a little bit what we need. You need like a bridge. So we're calling it a bridge program. And without the bridge, some people just don't see it. They don't see that it's relevant. But if the bridge program works, we think it opens up for all of the medical recommendations. A whole bunch of other things become, you know, understandable. I don't know if that helps, but so how do you get in? How do you build the bridge program?
Thanks, Kevin. Though I am somewhat disappointed you didn't juggle because, you know, I think this is actually one of the first times I've seen you speak without juggling, but, you know, you're forgiven. Anyways, it's really interesting, especially when I reflect back on the kinds of conversations we had at this seminar last month. And there was a lot of discussion about the barriers to digital health and also the desire for people to have interpersonal contact. And it's interesting also in light of the work we're doing together around newcomer communities and relationship to COVID vaccines, and how, again, the question is about what kind of information do you trust, who is it that you trust, and where you're getting the information. And a lot of people, again, trusted people who were healthcare professionals in their networks or family physicians and things like that. So it was very specific, and it was really helpful in what we're learning. And I guess when I'm hearing about thinking about all of this, I'm still an old hippie and worrying about the kind of machinations behind all of this technology. And I think, who owns the data when we have all of these things? And how is it being utilized? Whose knowledge is being promoted? And is it, and I was happy to hear you say you're talking about a bridge program and having that communication back and forth, because otherwise it's just propaganda if it's just going one way. And so I guess, I'm just wondering how you would reflect on those challenges. You could juggle later.
My cardinal rule was if you invite me for a keynote, I have to juggle. But I did do it. Sorry. I got salsa. I'll do salsa now instead of juggling. I kind of feel the same like Denise too, that I feel like it's like, with your children too, you want your children to be able to take advantage of technology, but you want them off the iPhone. So it's like, it's the same thing. Like, it's there, it's taking over, and it's as a parent, it's, I guess you're just trying to guide. So I should actually declare I have kind of a software patents and process for the gardens, which is a program that's actually meant to make data friendly and information friendly for patients. And I believe a lot of the things that's important is coaching. Like, none of this really works by itself. Even the diabetic speaker, that was only part of the treatment. They still needed the doctor and nurse to make them feel part of a system, to get their renewals. So it's never about leaving the computer by itself. I believe you need to have the coaches. So that's what I think. So coaching, and when their coaches need to be able to understand how to take advantage of the system as well. So I kind of feel like that's what I'm seeing, is that definitely we don't leave technology on its own. There must be some kind of background support or coaching or something. Because otherwise things could get really, sometimes you can go down the wrong path, and we all recognize the hallucinations. I don't know if people have ever experienced it. Have you guys ever experienced a real hallucination?
In the data.
On or off drugs?
So I was just doing this course, point of care ultrasound course, and there was exams and stuff. And I decided to put all the questions in ChatGPT 3.5. And I wanted to see how it would perform on these questions. And it did, very well. But on at least 10 questions, it confidently told me something that was absolutely wrong. And I could not detect, only because I was studying this stuff and I knew, I said, this is so convincing. It says it with such confidence, right? It's like, and it actually made sense. It made sense. Then I looked at it and said, that's wrong. They dismissed it, but it doesn't say, I'm not sure. And that was really scary when I thought, I actually couldn't tell the difference between, a fabulation or, confabulation or something. So that's where I do worry about this. We really need the guide. That's why I keep going back to the guide. We need like friends, we need, health nurses, practitioners. We have to stay involved in the process, because it's definitely not fallible.
I think we're at time, but sorry, Nancy. Right. Yes, we're a little past time, right, Ibukun? So, but please hold your question for lunch. And we have another speaker now. So thanks very much, Dr. Pottie. It was great. And thanks very much.
Thank you so much, Laura and Kevin, for a very engaging conversation. And I do think it's going to continue lunch into dinner because there's now much more to talk about. So without further ado, such a pleasure to welcome Kyla, third-year PhD student in medical sciences at the University of Toronto, who immigrated to Canada as a child following her parents from South Korea, often found herself assuming the role of translator for her parents during doctor's appointments. Her current research focuses on relationships between East Asian immigrant patients and their primary care providers, and she hopes to contribute insights to develop more culturally informed ways to navigate therapeutic relationships with East Asian patients. Beyond her academic pursuits, Kyla loves painting and watching Netflix with the family cat, all while continuing her role as translator for her parents. And as I invite her to the stage, I want you to keep in mind that she's the one who illustrated the hand-printed, colorful comics that you're holding in your hands. Welcome, Kyla.
Thank you, Ivakun. Okay. Hi, everyone. I'm very excited to be here today. So as Ibikun mentioned, my name is Kyla, and I'm a third-year PhD student at the University of Toronto. And today I just want to share with you a few lessons that I've learned during the first 3.5 years of my PhD studies, looking at relationships between immigrant patients and their primary care providers. But before I can talk about that, I think it's important to give you some background on who I am and where I come from. Before I begin, however, I would like to take a moment for a land acknowledgement. As an immigrant settler to this land, I acknowledge this land on which we're meeting today, as for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island who were forcibly removed, and I'm grateful to have the opportunity to live, work, and learn on this land. So, as I mentioned during the land acknowledgement, I'm an immigrant. I was born in South Korea to two people who took great pride in their careers. My mom was a pianist and a physics teacher, and my dad was a civil engineer. And when I turned 3, my dad received a really cool offer to work at a sister company branch in Mexico. So we all tagged along and we moved to Mexico for a few years until I turned 7 when my parents decided that they wanted to move to Canada. So we came here as economic immigrants. And then a year after we arrived, my younger brother was born. So if you have ever heard of the eldest daughter syndrome, if you Google it, you get hits of blog posts titled things like, "Are you okay?" or "Are you an eldest daughter?" If you add the word immigrant to the mix, you get the eldest daughters of immigrants are exhausted. So as the eldest immigrant daughter of my family, I played many roles growing up. And as I grew older, these hats changed and some stayed with me. One of the hats that I still wear often to this day is the hat of an interpreter. My parents took a lot of care to raise me to understand, honor, and respect my Korean culture. And so thanks to them, I am fluent in both Korean and English. But again, that gives me the title of in-house interpreter for the Lee family. So growing up, I translated letters from the CRA. At schools, I translated teacher reviews of my progress, which was awkward. And at the doctor's office, I translated symptoms. So while I don't translate teacher reviews as much anymore, I do translate still the occasional CRA letter and join in on doctor's visits. When it came time to apply to universities, I had no idea what I was doing. I was the first in my family to go to school outside of Korea. Somehow I figured it out, and in my 4th year of my undergraduate degree, I decided to pursue a master's in molecular neuroscience. This decision was largely informed by two kind of big experiences that I had. Firstly, migration put a great deal of stress on my parents, and I saw that firsthand growing up. The influence of the stresses of migrating and acculturating, navigating the language barriers, and the drastic reduction in social status really took a toll on my parents' mental health. And I had a biomedical background for my undergraduate degree, so mixing the biomedical background and the neuroscience mental health aspect, it seemed to make sense. Another was the story of my aunt. Years before this, my aunt had actually moved from Korea to join us in Canada in the hopes of starting a new life. But when the stresses, again, of migration and the language barriers started to make her episodes of psychosis worse, she received a deportation letter. And I remember her turning to the Korean community, often in the form of churches, to receive help in translating the letter and trying to get the order appealed. So collectively, these experiences that I had as an immigrant kind of led me to be interested in mental health, and so I decided to study molecular neuroscience. So near the end of my master's degree, I came back home one day to receive news from my parents that our family doctor of over 10 years was planning on retiring. She was also an immigrant, and so my parents had developed a really strong relationship with her over the last 10 years that we had known her. And I think that because she had also experienced immigration herself, her own experiences were really helpful in helping her understand my parents and vice versa, despite my parents' language barriers. So when I heard this news, I found myself wondering, how will my parents be able to find another family doctor that understands them and knows them in this short period of time? I began to wonder what the next relationship would look like. So, what mattered to my parents? Did they want to have another family doctor that was also an immigrant, spoke the same language, or did they just want to develop a relationship with them and then they'll figure out the language piece somehow? These questions ultimately brought me to realize that what I'd actually been interested in all along was immigrant health, not mental health per se. And I think looking back, the stories about mental health that I was interested in were actually stories of immigrant health. And so in the last year of my master's degree, I took a very courageous jump, and I did a 180-degree shift in my research field. I left the lab coats, the pipettes, and the goggles behind, and I came back home to Toronto to my family to study immigrant health in primary care at the University of Toronto. So as with the vast majority of graduate students, I experienced a very steep learning curve. So today I want to share with you a few learnings and insights from the first 3.5 years of my PhD. Before I began my PhD, I will admit I did not know a lot about qualitative research. I knew that it offered richness and depth that quantitative research sometimes couldn't, but I wasn't sure how and why qualitative work felt so personal until I learned what it was called, a reflexivity. So there are many different definitions of reflexivity, including attention to the researcher's role in research, a continuous self-critique and self-appraisal of how their own experiences influence the research, and I think this one's my personal favorite, a continual internal dialogue and critical self-evaluation of the researcher's positionality that leaves the researcher changed in its wake. The kind of work that I used to do in my master's did not give me a lot of room for self-reflection. But the work that I do now today really challenges me to take a critical look at my own biases, my assumptions, and my worldviews, which are all undoubtedly influenced by my own lived experiences as well. And then this in turn influences the kinds of questions that I ask as a researcher, the ways that I ask those questions, and the ways that I analyze and interpret the data as well. Growing up, being a Korean-Canadian immigrant was really core to the identity that I developed here. Many of my experiences with people, society, and the system were viewed and perceived through my lens of being an immigrant child. And when I started this work, I really liked how I felt so validated and seen in the literature on immigrant health. A lot of studies talked about how newcomers and immigrants can't help but neglect their health because they have to prioritize survivalhood. They can't afford to take time off of work because the doctor's clinic is only open 9 to 5. They have so many family obligations to tend to, sometimes they can't even make time for it on the weekends. But it became clear to me over time that not all immigrants are the same. I had learned about intersectionality in class, but somehow my own assumptions and perceptions preceded it. So intersectionality posits that social positions that exist on a hierarchy of social power interact and intersect to shape experiences. Therefore, shared migrant status or ethnicity is not synonymous with shared experience. So these experiences can be shaped by a multitude of factors, such as the immigration category, the conditions with which they enter Canada and or leave their home country, socioeconomic status, social status, education back at home, race, culture, gender, language spoken, all sorts of things. And so the use of summative or aggregated data can often fail to accurately represent immigrant experiences and stories. For example, although I'm also an immigrant myself, I am acculturated, I'm fluent in English, I received all my education in Canada, I'm pursuing higher education, and I am a child of immigrant parents who chose to immigrate here under their own conditions. So this is a lesson that I'm hoping to keep at the forefront of my mind as I continue to engage with various immigrant populations, including those of the same ethnicity as me. Much of the research that I came across in my doctoral studies during literature reviews and such often grouped various immigrant groups together. So some would group them from different countries of different continents and lump them all together as just immigrants, while others would be more intentional and group immigrants of different countries, at least from the same continent. But what I have learned over some time during my doctoral studies so far is that even those from the same country can have very different experiences with immigration as well as cultural backgrounds, especially if it is a big country. And so when I started asking questions about immigrant patients, specifically Korean immigrant patients and their relationships with their doctors, I began to wonder to what extent what we already knew about patient-doctor relationships were actually applicable to these specific immigrant groups. So that led me to conduct something called a simultaneous concept analysis, which is a large review of the concepts in the literature that aims to distinguish between concepts and to clarify their relationships. Specifically, I chose 3 concepts that are quite often used in the literature to describe some aspects of the patient-doctor relationship, namely patient-centered care, the therapeutic alliance, and shared decision-making. So in the last several decades, the ways that we understand health has changed dramatically. We used to think of it as something that was just purely biomedical, but over time we've come to acknowledge and understand the ways that psychological and social factors can really influence your health. And so that led to a shift in thinking concerning patient involvement in their own care as well as patient autonomy, and eventually led to the introduction of the concepts of shared decision-making, patient-centered care, and the therapeutic alliance. So these 3 concepts, again, describe some aspect of the doctor-patient relationship in all sorts of different care, and adoption of these processes are thought to generally indicate quality care internationally. However, when we start looking at the concepts in more detail and we start wondering, okay, so how do these theoretical concepts get actually operationalized and implemented in practice, it gets a little bit blurry. So there aren't that many agreed upon definitions for either of these 3 concepts, particularly in primary care where relationships are really developed between doctors and patients over a long period of time. And so this concept analysis, I really tried to figure out how these concepts differed, how they were similar, and how they interacted to really get at the core of the indicators and operationalizations of these theoretical concepts. Today, I just want to share with you two themes that emerged from the concept analysis. So caring and sharing. So caring is described to be something that is largely done by the provider. It refers to the provision of emotional support, the development of rapport, positive regard, taking a non-judgmental stance, and giving care in a compassionate way. It emerged as key traits of the therapeutic alliance, which is like a model of the doctor-patient relationship, as well as patient-centered care, which is an approach or a way of giving care. Sharing, on the other hand, can be done by both the doctor and the patient. So it refers to the sharing of information. So that's biomedical information about the different treatment options, the benefit to risk ratio, so on and so forth, by the provider. And then from the patient, sharing of information about their preferences, their lifestyles, what is actually feasible for them to implement in their lives. It also refers to the sharing of goals, agreement and collaboration, as well as shared power in the relationship. Sharing emerged as key traits of the therapeutic alliance, as well as shared decision-making, which is a process that's embedded within patient-centered care that enables collaboration between the doctor-patient dyad. Also from the concept analysis, 5 overarching iterative and quite often nonlinear steps of the shared decision-making process emerged. So very briefly, shared decision-making can start with a conversation about preparing for the conversation itself. So not all patients are equally kind of ready to engage in these kinds of conversations. Not all patients are aware that this kind of conversation can even exist. So in the beginning of this process, the doctor and the patient try and reach an agreement on the problem that needs to be solved, and then the doctor often opens up a conversation surrounding the potential for the patient being involved throughout this process. Next is the information exchange, again, where the doctor shares information about the different options, the pros and cons, so on and so forth, and the patient shares information about, okay, yeah, that sounds feasible, I can do that. No, I don't think I can do that. Here are my values, these are my preferences. And then the doctor and the patient go on to deliberate together. So to deliberate means to think carefully about the different options and the consequences that it can carry. And deliberation can actually happen outside of the clinic as well. So more recent models of shared decision-making actually suggest that the patient should take the information home that they receive from the provider and continue to co-deliberate with their family and friends. And if the need arises, consult with a second opinion. And then they come back to the provider where they ensure that the direction of the decision that they're headed towards does indeed honor and incorporate the patient's preferences. And then finally, they make a decision together. So existing literature on Korean immigrant experiences are, as I mentioned earlier, largely drawn from amassed findings of East Asian immigrants as a whole. So these studies report that East Asian immigrants are less likely to be encouraged to participate in shared decision-making with their providers. They're less likely to establish rapport with their providers, and they are also less likely to receive sufficient information from their provider. Reports on their preferences for the degree of involvement in this decision-making conversation also vary. So some report that they like to take on more passive roles where they largely like to depend on the provider's advice and recommendations, while others suggest that they also like to take on active roles. So these discrepancies in the literature can be due to several things, I think. So a lot of East Asian immigrants come from collectivist cultures where they largely value authority and hierarchy. And so when a doctor offers choice, some newcomers of East Asian descent may perceive it as a lack of authority and expertise on the provider's end. As well, doctors may believe preemptively that patients are just not interested in taking a more active role because of language barriers and difficulty in articulating their preferences. As well, some studies found that patients might misunderstand what involvement in decision-making actually entails. So a few studies found that immigrant patients thought being involved in their decision-making meant that they make the decision entirely on their own without any advice, recommendations, or input from the provider, which is not shared decision-making. So to address this, I am in the middle of planning a qualitative study with immigrant patients to look at their experiences and preferences with decision-making within the relationships with their primary care providers. I hope to explore whether relationships like this are meaningful to Korean patients, and through my doctoral work, I hope to add to a growing body of immigrant research that is purposive in nature, and I hope that my work contributes to better understanding the needs of Korean immigrant patients like my parents, and then ultimately for more culturally and contextually appropriate guidelines. I look forward to more lessons learned throughout the rest of my doctoral studies and hope that these lessons continue to foster both my personal and professional development. Thank you.
Excellent presentation, really enjoyed that. And I think you brought up some elements that are really relevant for my work when I work with people just arriving in Canada. The only thing I didn't quite hear was the concept that things are not concrete and they could be dynamic and changing. So there could be a transition that can happen or not happen. So I wonder if you're kind of considering that as well. Maybe some people can transition to more agency and some people can't. I don't know, what do you think about that?
Yeah, I think that's a great point. To be honest, I'm not really sure what to believe in the literature about their preferences. But definitely the factor of acculturation, I think it can even go as far as to change people's personalities. Like speaking from my own personal experience, my parents' personalities have changed a lot in the last 20 years, and I think a lot of it was due to the stresses of immigration and the difficulties of being misunderstood and feeling like the words that they want to, get out are getting stuck in their throats. And so I definitely do think that time is a big factor in changing preferences for the degree of agency as well. And of course, like the age cohort differences and even, their educational background, the different kinds of conditions that they have. I think there's also a difference between whether you have a chronic condition or whether it's more acute. Patients with chronic conditions tend to know more about their bodies and advocate for themselves more strongly. So yeah, I think there's definitely an influence of that, but I don't think I found any of that in the literature, unfortunately, on those concepts.
Thank you so much, Kyla. I'm just going to ask one more question. I love the way you told the story about how your personal life sort of led you down your focus in research. How do you see your personal and academic journey now evolving beyond your PhD, which you're going to finish soon? And what impact do you hope that is then going to have on immigrant health research?
Wow, that's such a reflective question. Well, first of all, yeah, I also hope that I finish my PhD soon. Who knows? In terms of professionally, I'm not really sure yet. I think I'm just taking opportunities as they come, so long as I feel like they align with my values both professionally and personally. I think, for example, this comic is such a great example of that. I've always loved drawing and kind of creating things, and I never thought that I would be able to come across an opportunity to kind of merge my passions for doodling and immigrant health together. So, and I also think that there is a barrier. So even academics in Korea, everything's disseminated in English, and they're all difficult words. So I think that knowledge translation piece is also really interesting to me. And there are so many different creative ways to go about it as well. And then personally, recently when we printed these comics, I brought a copy home, and I brought 2 copies home, and I saw both my parents reading it over the dinner table, and I took a picture of it, and it was actually the first time that my parents actually understood something that I did at work. So personally, it's really rewarding as well. So yeah.
Thank you for sharing that. Okay, one more question. Nancy?
I can save it. Okay. I can save it. Hold on. It's not going to go.
A great presentation, by the way.
Thank you.
I do believe that most of us face the same experience with our parents not being born in Canada. Just one simple, easy question. If you had no barriers, right, what would like a perfect scenario of what you're trying to present here would look like in whichever year? Like, you know, what would like an ideal scenario look like down the line if you had no barriers? Yeah.
For immigrants accessing primary care?
Correct. Right.
No barriers? Like no money, time, nothing like that barriers. Okay. Well, ideally, when newcomers enter Canada, they're given language appropriate, culturally appropriate resources on exactly how to find a family doctor, where to go, the different systems. So for example, if you're registered with a family doctor, sometimes they prefer you don't go to a walk-in, and so on and so forth. There are different systems, right? Things like that, the way the system works, all in the language that they speak. And then online booking, all sorts of things like that, technologically advanced. You get to the doctors, the translators and interpreters are there, or you have like a device that you put around your neck and then it just translates for you. Enough time, reduced administrative burden, so many things. But I think if I had to pick one, it would just be the language portion. So whether it's resources that are tailored to their language or interpreter services that are more widespread.
All right, thank you so much for that. So now we move on to the first presentation from our 4 panelists. Gives me a lot of pleasure to welcome Professor Michaela Hynie, who is at the Department of Psychology and a resident faculty in the Center of Refugee Studies at York University, and an honorary professor in the School of Medicine at the University of Rwanda. Dr. Hynie conducts interdisciplinary, multi-method, community-based research on the social determinants of health, with communities experiencing social conflict, social exclusion, or forced displacement and migration. Her work includes the development and evaluation of social, institutional, and/or policy interventions that can improve mental health and well-being. She's been funded by CIHR, Grand Challenges Canada, IDRC, as well as SHIRK, and her work is primarily located in Canada and Rwanda, and has additionally been situated in India, Kenya, Nepal, and South Africa. Her recent research includes work on maternal mental health in Rwanda, access to healthcare for refugees and people with precarious migration status in Canada and South Africa, and the relationship between state refugee policies and health and well-being in Canada, Germany, and South Africa. She is the past president of the Canadian Association for Refugee and Forced Migration Studies, and I'm so honored that I can also call her a mentor and a friend. Michaela.
Thank you so much for letting me come to speak with you today. I'm going to try to, I hope, make this a relevant talk. Having seen the talks this morning, I feel like you've covered everything I want to say. So maybe I can just sit down now. But what I'm going to try to do today is actually talk about the value of theoretical models, which is exactly what you want to hear at the end of the morning before lunch, right? And I want to start by saying that for many years, my colleagues and I have been trying to bring integration theory into research on the social determinants of health, and particularly mental health, with refugee newcomers. And the reason that we've been trying to do this is that very often when people work with refugees, they focus on the traumas that they experienced prior to coming to Canada. But just as Dr. Pottie mentioned earlier today, there's this thing called the healthy immigrant effect, and we have also found a healthy refugee effect, where despite coming from situations of conflict, you would assume people's health and mental health would improve on arrival. But in our research, we have been seeing refugees' health and mental health actually get worse over time. And we see that thinking about integration within the social determinants of health can help us really focus on why that's happening. I am sure that you are all familiar with the social determinants of health model, but it draws our attention away from the biological determinants of health to social and structural determinants of health. And we've been trying to argue that you should think about these through an integration lens when you are trying to predict the health and mental health of refugees. There are two things I want to talk about that are particularly important for what I want to say today, and one is the emphasis on health equity, that groups have different health outcomes because they have differential access to important determinants of health at the levels of material conditions, their ability to engage in health behaviors, which are themselves determined by inequitable access to things like education, meaningful and appropriate occupations, adequate income, and freedom from the experience of discrimination, social exclusion, and other kinds of social tensions. And that if you go further upstream, as people have mentioned today, that these conditions are shaped by higher order policies and cultural norms, policies around migration, policies around labor laws, policies around access to education, housing, and that if we don't think about how policies are affecting and shaping these downstream determinants, we cannot really effectively change and affect people's health and well-being. So we've been trying to talk about integration in this context to say, if you really care about the individual health outcomes of your patients and clients, you need to be thinking all the way up to these determinants. Okay. What I want to do today is flip this around and say, when we talk about integration, we need to be thinking about the social determinants of health. Because I think that thinking about the social determinants of health can help us save integration theory. So why do I think we need to save integration theory? I'm sure it's not going to come as a surprise to you to know that we are seeing increasingly restrictive policies around asylum and around the support that we provide for refugees around the world. We are finding that asylum policies are more restrictive. It is harder to achieve asylum. We're finding that the conditions people have to live in and the processes they have to go through while they seek asylum are becoming more restrictive. And we are seeing that governments are providing increasingly restrictive social welfare conditions for individuals living in asylum or living as refugees in their countries. And I'm particularly here focusing on high-income countries. And what we have been seeing is that the language that's used to justify these policies, policies that are intended to be exclusionary, is a language of integration. There are claims being made that refugees, asylum seekers, and immigrants are failing to integrate, and that because they are failing to integrate, they are a threat to our societies. What we are hearing from policymakers and what we are hearing in other forms of social discourse is language that says, I'm going to focus here on refugees, but you can replace that term with asylum seeker or immigrant. What we are hearing is that refugees are failing to integrate into our society, and they are therefore a threat to our values because they don't share our values and our customs. I just want to pause for a moment and ask you, what is this single unifying set of values and customs that we all share as Canadians? There isn't one, right? and that they are a threat to us financially and socially because they are an economic burden to our society. Now, one of the reasons that people can get away with making these kinds of claims is that the very term integration is not really defined. We have this fuzzy notion of what integration is, and people use the term integration in different ways to mean different things in different contexts, depending on who's speaking, who they're speaking about, and why they're speaking about them. And it is the fuzziness of the language of integration that makes successful integration an impossible goal for individuals who make these claims, and that create friction around the language of integration, so much so that the theorists that I cited on the previous page are arguing that we should do away with the term integration altogether. It is now being used as a weapon rather than as a useful tool for promoting the support and settlement of newcomers. There are some reasons to go along with that argument. But as somebody who does a lot of applied research, I work with settlement organizations, I work with community organizations, and we want to be able to develop settlement programs, and we want to be able to evaluate those programs, and we need to have some kind of concrete, usable, pragmatic tools to do so. And throwing out the term integration, I don't think that's going to help us. So I'm here to try to save integration. And I think that thinking about it from a social determinants of health lens can help us. So what are the debates that we're hearing in integration? Well, one is what dimension we're actually talking about when we talk about integration. So when we're talking about the ability of newcomers to form relationships with people from other communities, when we are talking about people's ability to participate fully in society, we're talking about social integration. When we are talking about material integration, typically this is where we see policymakers being very interested. We're often talking about labor market participation. And with that, people also often talk about education and language as determinants of labor market participation. I just want to flag, as other people have, that language actually is critical for all of these levels. And then sometimes they also talk about what we might think of as psychological, subjective, or emotional integration, which is the feeling of belonging, of being at home, of saying, I am a Canadian. And there are others who say that until somebody feels that they're at home, they haven't really achieved a feeling of integration. If we don't all feel at home here, we are not all experiencing integration. That's one area of debate. And again, people will use different kinds of integration when they're talking about failure to integrate. The other thing that we've been talking about in this room, but that we don't see talked about very much in integration theory, is intersectionality. I was conducting an evaluation of an integration settlement support program for government-assisted refugees and interviewing people across Canada, and I spoke to a young man who had come from Kakuma in Kenya and settled in Newfoundland. And his mother had a very serious health issue. And he had to accompany his mother to all of her healthcare appointments because she could not go on her own, both for her health reasons, but also because she did not speak English. His English was okay, not great, but good enough to do the interview. Because he had to accompany her to many appointments and they were unpredictable, he could not regularly attend language classes because they have a minimum attendance requirement. Because he could not complete language classes, he could not attend university. He could not get a job. And when he talked about his experience of living in Canada, he said, for my mother, this has been a great experience. She now has a safe, comfortable home. She can access the health care that she needs. She feels safe here. But for me, there is nothing for me here. I was better off in the camp. And I think what this highlights is that when we think about successful integration, what that means is very different for different people, depending on their expectations, their hopes, their dreams, and the resources that they have available for them. And very few of our models of integration actually capture that intersectionality. And the last piece that we have also seen spoken about here is this tension between one-way and two-way integration. Everybody pays lip service to two-way integration. The EU talks about two-way integration, how important it is that we recognize that our societies are made up of the people in the society, and therefore societies change when new people come into the society. And yet when we develop programs and when we evaluate integration success, where do we focus? We tend to focus on changes within the newcomers. And we often take a highly assimilationist approach to integration, where our measure of success is how well do newcomers change themselves to fit our imaginary typical Canadian. So do we throw out integration? We have tried to come up with a model that can address these different levels or different ways of thinking about integration, and that we can still use to guide interventions and to guide evaluating whether those interventions have been effective. And what we have done is modified a very widely used integration model from Ager and Strang called the social integration model, and simply expanded it a bit to try to accommodate those multiple levels. And we think this is useful because it helps us organize our thinking around the incredibly complicated process that is integration. That middle level is what you might think of as most often seen in the material integration literature. And that is the extent to which people can navigate in the language in the place that they are living, their ability to navigate the culture, both the physical culture and the social culture, and then what Ager and Strang would call the markers and means of integration, which are the functional aspects of housing, education, employment, and healthcare. And we recognize the ease with which people can navigate those things depends on their own personal history, whether they can read in their own original language, their level of education, whether they're coming from a rural region to an urban setting, etc. The individual subjective psychological level of integration we try to capture in the sense of belonging and the sense of safety and security. And that broader upstream social context level we capture in the top level, which we call the social level, where we talk about social connections, your ability to form relationships with people within your group, within your in-group, and with people from other groups. The extent to which the community is welcoming or discriminatory and exclusionary, and the extent to which institutions adapt to meet the needs of the clients using those institutions. And then we've tried to capture both the nature of the overall environment through the socioeconomic context. If you're moving to a place like Toronto that has limited housing, then housing is going to be a challenge. It's going to be a barrier in your settlement process. And also social identity. So your age, your gender, your religion, your race, these are factors that are going to shape your integration process at all of these levels. I want to focus here on the social level because all of these levels are interconnected, but the social level is often most clearly connected to our policies. And I want to talk about the connection between thinking about policies and thinking about what happens at this social level. And just to give you a couple of examples, focusing primarily on language. I want to start with institutional adaptation. And this is a quote taken from an interview from a recent study we did with Yazidi newcomers in York Region. And we started working with Yazidi newcomers because the providers in the region said we were completely unprepared for providing support for this community. Here is a quote from one of the service providers saying, with the Yazidis, we had 2 weeks' notice. We had no sense of how much language they spoke. All we knew was that there were single parents arriving with small children coming from a community that faced multiple persecutions. We were left on our own to do all the research. That resulted in a number of missteps with this community, including the provision of Arabic-speaking interpreters because the Yazidis were coming from Iraq. Many of them spoke very little Arabic. They associated Arabic with the language of their persecution, and it resulted in undermining the trust between the Yazidi community and the service providers. Providing institutional adaptation or allowing institutions to adapt to multiple waves of newcomers means that you need to be able to provide training. That means you need to provide information. That means you need to provide the resources that the agencies require in order to train their staff. It also means, and Kyla alluded to this, that you need to have time when you're interacting with newcomers to actually accommodate their needs. So one of the reasons that we see so many problems with interpretation is partly because it's really time-consuming to get interpretation organized. The staff don't have time because there aren't enough resources in these services in order to take more time with people who need to navigate new services. And you need to have policies that are flexible enough to meet the different needs of the newcomers. We conducted a project in Ontario, British Columbia, and Quebec with about 2,000 Syrian newcomers who arrived between 2016 and 2017. I will talk a little bit about this research today. One of the things that we looked at was just with the people who came to Toronto. There are about 530 people in this sample. In the first year of arriving, Over 35% of them said that they did not receive interpreters at some point when they needed to during an appointment. I also want to look at another aspect of language, and this is access to language classes. So again, we're in 3 provinces, and we see that a large proportion of the newcomers are actually accessing language classes in their first year. I just want to highlight the items in red here. Not everybody accessed classes to the same level. For example, if you didn't need an interpreter, you didn't access language classes because you already spoke the language. But there were particular groups of individuals who had particular barriers around accessing those classes, and those barriers can be thought of from the perspective of policy. Women, people who were employed, people who had small children, and people who were experiencing poorer physical health. We spoke to a number of service providers in each of those provinces to find out how those services were being delivered in the provinces. And what we heard was that the women were facing barriers around transportation. Most of them didn't drive. They would have to access transportation on their own. They found that difficult or intimidating. Not every province provided transportation costs, so it was expensive. They would have to bring their children with them if they had young children. They would have to access programs that had childcare, which were few and far between and often located far away, and they often had waiting lists. They were also uncomfortable in mixed gender classes and in community classes, and yet single gender classes were not being offered. We also saw people talking about families having to choose between providing working or providing care either for children or for family members with health care problems, or having to choose between work and language classes. And I want to draw your attention to some work by Heba Gouayad, who did a really interesting series of studies comparing what was happening in Canada, the United States, and Germany with Syrian newcomers. And she highlighted that, particularly in the United States, which has the most restrictive settlement support, the men in the families that she was working with were forced into employment as early as 3 or 4 months after arrival. They often didn't have chance to take language classes. They were forced into precarious, difficult, dangerous, low-income labor, and they stayed there because those jobs did not afford them the opportunity to improve their language and have other job opportunities. So again, you can see this connection between policy and integration outcomes. Also, language classes and work often happens at the same time. So if you choose work, you don't choose language classes. The strict absentee policies also meant that people who were dealing with difficult healthcare problems failed to meet the attendance requirements and got kicked out of the classes. I want to very briefly talk about the 2 other dimensions within this social context. One is around community attitudes. Particularly in the context of asylum in Canada, we have been seeing really negative discourse being generated by policymakers around asylum seekers, and this shifts attitudes towards newcomers in general. So we have seen the Premier of Quebec talking about asylum seekers being bogus refugees. They are dishonest, they are lying to us. We have seen them talk repeatedly about how expensive it is for us to provide support for newcomers, and this also shifts attitudes to be more negative. Negative community attitudes have been associated not only to this kind of negative discourse, but also to the social stigma that we attach to poverty. So the fact that we provide such inadequate income and housing for newcomers also means that they now carry an additional stigma, which is the stigma that we attach to people who are poor in this society. The constant criminalization of migration and of migrants leads to negative attitudes, and the perceived or real competition for resources, apartments in Toronto, for example, shifts attitudes towards newcomers. At the same time, I want to point out that policies that promote community consultation and community involvement in building community welcome shifts attitudes to be more positive, and there's a lot of literature around that. So there are things that we can do to make things better. And lastly, social connections, building relationships required safe spaces where you meet with people as equals, in the classroom, at work. And that's where you not only build social relationships, but you build all of the other levels of integration. This is from a youth focus group, and this was a very insightful comment from one of the youth. You need to go through education, and of course go through school. Going through school, you get connected to the community. You get to know the different cultures, because at school you meet many people and make friends. And you feel more comfortable in the community where you're living. Every level of integration. And when we talk to newcomers about where they make friends outside of their communities, it's in their language classes. So, to state the obvious, all of these levels are connected. Again, thinking about policies that limit language means that we're also looking at policies that are limiting people's access to employment, and that we are then limiting their access to income security, and that we are increasing social isolation. When we look at policies that don't allow institutions to adapt to the needs of newcomers, poor service also results in the undermining of people's trust in the institutions of the society, and that then leads to people feeling like they don't belong. And finally, negative attitudes and discrimination obviously hinder people's ability to form relationships, but also mean that they face discrimination in accessing employment, in accessing housing, and undermines their sense of belonging and security. And I could go on and on and on, showing how these things all interconnect. So why social determinants of health? Because if we think about integration taking a social determinants of health lens, it asks us to think about access, equitable access to the determinants of health. And those are also equitable access to the determinants of integration. It's not about charity, it's about equity. The other thing is that it asks us to look at upstream factors. And if we really want to make broad, sweeping changes, we need to really be thinking about policy and working on how policy can change people's access to integration. And finally, we need to constantly be thinking about how this is holistic. These levels are interconnected. And so these two models, to me, work very closely together and are helpful in thinking about how we evaluate how well we're doing as we try to support newcomers in our society. Thank you.
Thank you so much for the presentation. First of all, I really apologize for asking so many questions, but this is really close to my heart. I've been in the field for the last 10 years. The first, up until 2020, I've been volunteering, but after COVID, I started my startup. So every time I talk about these problems, I feel like I have to explain a lot of these problems. So this presentation was like, oh my God, like I've not sat down for 3 hours, 4 hours, just resonating. Like this is like full resonance. So thank you again. My question is, because I'm just thinking about the end goal here, right? So let's say, what would be your mission statement? Like what would you see as the outcome of your efforts, right? And how do you see it being like realized? I guess, yeah. Thank you, and sorry for the question.
Well, that's an easy question, thanks. I mean, I think of integration as creating policies that will create conditions that allow people to fulfill their potential and their dreams, period. I think you have to recognize that not everybody wants the same thing. So we need to listen to people to hear what they want. We need to work with them and work with communities to help them achieve their goals. We can't make decisions for communities about where they want to go. So when people are talking about doing participatory development of technology, participatory development of integration strategies and settlement programs, that communities need to be supported to work to achieve their own goals.
Thank you so much, Michaela. I really appreciated this talk. And I wondered just in reflecting on your work, if the notion of citizenship has come up, particularly when you talked about an assimilationist ethos. And one of the and I really also appreciate the fact that you brought gender back to the foreground as a structural determinant for integration, especially for people that have experienced forced migration. But coming back to the question around, has that notion of citizenship come up at all in some of your work and findings in relation to what makes people feel belong and integrated? Because one of the things that I learned just recently was that sometimes people have not ever integrated. So what can we offer as a society in Canada and that whole notion around citizenship? Just your reflections.
I want to come back to this question of being able to achieve your goals. And we often ask people what would make you feel like you belong. And it's kind of prosaic. Many of them will simply say, I want my family here with me, and I want a job. And not a job that allows me to achieve what I know I can achieve. So a job that's commensurate with my skills. And that's a gendered response in many cases, but not always. And those things are often prioritized partly because people are really struggling for family reunification and really struggling for employment and appropriate employment. But people will also answer that question differently. And it comes back to what you need to feel like you belong, what you need to feel like you belong here will to some extent be determined by what you're hoping to accomplish here, what you're hoping to achieve here. And if you can't achieve what you hope to achieve here, will you ever feel like you really belong here? So it might be becoming an artist, it might be becoming a parent, it might be seeing your kids go to university, it might be just a safe home and having your family here with you. The other thing about integration, this is a bit of a tangent, but I've worked a lot with the Karen community, and there's this interesting thing that happens in communities like the Karen, which are very close-knit here, as opposed to other communities which can actually be quite fractious. And they operate on almost a hub-and-spoke kind of model of integration, where the community takes care of itself, and then they send out individuals who act as bridges with the larger society. And that works, and they are able to navigate to take care of themselves, and it's often their youth who then do that work, who carry the burden of doing the integrating for the community, but the next generation then moves into those roles. And so those communities change over time, and we have these incredibly unrealistic expectations of how somebody who's at the age of 50 who doesn't read in their own original language arrives in Canada, and oh, by the way, in a year, can you be fluent, get a job, and get on with it. And I think if you realize that people will integrate into society in different ways, will support themselves and each other in different ways, we will move towards a sort of a sense of community where yes, we belong here because we're allowed to spend time with the people we spend time with. I mean, how many people who claim that immigrants aren't integrating are socializing with people outside of their own community groups? One could argue that they're not integrating. Right? So there are these funny, yes, we can be divided and fractious. Yes, we lead very different lives in our society. And the Karen community, when we were the people that we worked with who were the older Karen didn't want to be supported by people from outside of their community. They wanted to be able to support each other, but they also had connections to that larger community. The same thing with the Yazidi, who said, they didn't trust institutions, they didn't trust people outside of their community, but they would develop relationships with individuals or with individual providers. Their children will eventually be just like all the other kids in the school. There is this transition that happens, but it doesn't happen overnight, and people achieve it in different ways. But if you don't allow them to achieve it in the way that they feel comfortable, that works for them, the process will be longer and more difficult, I think.
Okay. Thank you very much, Michaela. I think we've come to the end of this phase of the session. Another round of applause. We're going to do a more detailed Q&A after the other panel presentations after lunch. But first, lunch. So lunch is outside. If you indicated dietary preferences on the table to the right, there are labels for different dietary preferences. So just figure out yours, pick your box. Lots of questions and chats for networking during lunch. We'll see you back at 1 p.m. Thank you very much. Enjoy lunch.